Personalized medicine is a way of practicing oncology that many of us would like to move towards. There's a number of different aspects which have been shown in the solid tumors and other aspects of hematology, but in multiple myeloma, we've really not been able to move very far forward in personalized medicine. The sort of examples that we've been able to achieve, for example, would be by taking out different subgroups of populations for a different type of treatment. One of those might be identifying high-risk patients by means of cytogenetic analysis and giving them more intensive treatments. But perhaps a more biological approach is by performing tumor profiling or molecular profiling to try and understand the biology of patients and give a treatment based on the molecular signatures. Now, this is being performed in multiple myeloma, and there's a number of basket and umbrella type of trials which do investigate this. So, for example, you can molecularly profile a group of patients and take out, for example, the BRAF mutations and then give them a targeted treatment for this, or mutations within the RAF pathway, and treat them with a MAP kinase and MEK inhibitor. So those sorts of trials are ongoing, and certainly we've seen some anecdotal data showing that targeting of the RAS pathway is beneficial. But the other question is, how can we take this further forward, and can we find driver mutations? Because this is always the problem in myeloma, which is a disease made up of multiple clones, where you can easily target subclones but not truncal mutations. So moving forward, what we do find in terms of myeloma profiling is that there's a couple of biomarkers which are probably ripe for targeting in terms of personalized medicine. The first is BCL-2 and the second is MCL-1. Now, MCL-1 is still a very experimental approach for targeting, and we've only seen very preliminary data with MCL-1 inhibitors, and that's an area that needs to move forward. But certainly what we do see is that myeloma cells seem to be very addicted or dependent on the MCL-1 signaling pathway. But a variety of cancers are reliant on BCL-2 signaling. And BCL-2 is a pro-apoptotic molecule which is highly expressed in a number of different subtypes of myeloma, as well as CLL and other types of cancer. Venetoclax is a selective oral BCL-2 inhibitor and has shown efficacy in CLL and also in AML. And in terms of personalized medicine, the data on venetoclax is very intriguing. What we see is that in terms of monotherapy, it does have an effect in patients, broadly speaking, with multiple myeloma. The overall response rate is about 20 to 30%. But if you look at the subgroup of patients who have an 11-14 translocation, the response rates are in excess of 80%. Now, when you look preclinically, you can sensitize a further subgroup of patients who have high BCL-2 expression, as well as the patients with an 11-14 translocation, by means of giving bortezomib. And so when you give bortezomib in terms of a phase 1 clinical trial, the response rates were 90% for patients who have BCL-2 high expression, either by immunohistochemistry or by qPCR. So this is an approach that's been taken forward and was moved forward with the phase 3 Bellini clinical trial, which looked at the combination of venetoclax, bortezomib, and dexamethasone versus placebo, bortezomib, and dexamethasone for patients with relapsed myeloma who've had between 1 and 3 prior lines of therapy. These results have been previously presented, and there's an improvement in overall progression-free survival for patients receiving venetoclax, but what was surprising was that there was an excess of mortality for patients receiving venetoclax. So to try and understand that, you need to understand the subgroup analysis, and this data has been presented at EHA this year. And what you find in the subgroup analysis is, again, that cohort with T11-14 translocation does incredibly well, with a significant improvement in PFS. Hazard ratio is about 0.2, 0.3. And you do not see that excess of mortality. The hazard ratio is below 1 for the 11-14 group. And then if you look at the other subgroups, which is the high-risk cytogenetic features, you find that they don't benefit so much from venetoclax, and they do seem to have that excess mortality. So I find this data really intriguing because it tells us a little bit about the biology of myeloma in a way that we've never understood before. And what we see with this targeted agent, that there is a certain group of patients that do very well with venetoclax, but there's a certain group of patients where you should not give venetoclax through. And that really is a very good example of personalized medicine. And so I look forward to more data for venetoclax coming through. The CANOVA trial is the phase 3 trial, which is randomizing venetoclax versus pomalidomide, and will tell us whether this agent is superior in the context of T1114 myeloma.